Hello, everybody. It's nice to see so many friends already coming online. This is our February 8th Gravity Public Meeting for the Terminology Division, or wing, or work stream. It's been a long day, so I'm mixing my words. This is the formal Utility and Security Kickoff, where we get joined by our SMEs. We'll start a few minutes after the top of the hour to let everybody join. And we are so excited to see so many friends again. We missed you all. Funny. Hi. All right, so we're going to, again, welcome to the Gravity Project Terminology, Utility and Security Kickoff. We're going to start probably at 4:04, just to let people arrive. As people are joining, what we try to do as a custom is ensure that everyone knows who's on the call. So if you want to drop in your name and the organization you hail from, that'd be great. We're entering our 5th year. We're closing our 5th. I mean, we've been around a long time now. So, well, a long time in the grand scope of things, but given that we thought it would be a 1-year project. So please put your name in the chat with where you hail from in the organizational sense. If you want to put where you hail from geographically, you can do that too. We are so excited to see you. Again, we're going to start in about a minute. All right, here we go. It is so good to see you all again. My name is Sarah DeSilvi. I have the honor of being the Director of Terminology for our Dear Gravity Project. This is our beginning of the Spring-Winter 2024 terminology build. We're going to be doing the formal consensus work on utility and security. Depending on a few moving pieces, we might be adding layers of things into this meeting as we go into this session as we go forward. But utility and security, as planned, kicks off today, and we are joined by our wonderful subject matter experts who you'll meet later in the call. Next slide. Welcome. We used to be that there was a ton of attendees. We're getting to be a tiny, and not tiny, but enough of almost a consistent group of folk that it's a little bit silly to call us large now. But everyone is muted upon entry, and we ask that you remain muted just because of the Zoom courtesies to avoid background noise. The call is always recorded. Everything we do is recorded for posterity and available on the Gravity Confluence after the call. We do try to keep a lively chat going, and that we try to pause in the moment and have kind of a seminar feel regarding our work. So please send Zoom comments to everybody so that everyone can see them. And just as a courtesy, remember, if you send them directly to any one of the presenters or myself, it's likely to be read out loud because it's very hard for me to differentiate private messages from public messages. So assume if it's in the chat, I might say it. All right, and then next slide. This is our necessary antitrust practices slide. So Gravity has the responsibility to comply fully with federal and state antitrust laws. Any individual speaking or providing written comms shall refrain from any discussion which may provide the basis for an inference. They have agreed to take any action related to prices, services, production, and allocation of markets, or any other matter having a market effect. Shall not discuss pricing or other pricing or any term that might affect pricing or fees, such as costs, discounts, terms of sales, or profit margins. Adherence to these guidelines involves not only avoidance of antitrust violations, but avoidance of behavior that might be so construed. I read the whole slide this time. I will abbreviate in future sessions so that we can just try to trim the background. But this is a slide that we'll revisit every single time. Next slide. I think.
Do you get the next?
I don't see the slide moving. Am I the only one? Uh-oh.
I see announcements. An agenda.
Seven.
Everyone, this is Sarah Bahal. I believe Sarah DeSilva dropped, and she's joining us again.
I got booted. Good old Vermont terminology, Vermont digital access. Is someone else presenting this slide, or should I keep on going? All right, I'll keep on going. I am Sarah DeSilva in rural Vermont. I'm like a good example of digital access on any given day. Today was no exception. So the agenda as follows. Again, my apologies for disappearing and then coming back. We're going to do a general overview, announcements. Because this is the first first meeting of a session of Build, we're going to do a little bit of Gravity overview about what we are, our work streams, very brief. We try as a courtesy to make sure we bring back any updates to terminology and any updates on submissions. And so that section will be kicked off, led by Hamali, and I'll have a little bit of commentary there. And then we have the honor of centering the wisdom of our amazing subject matter experts, some of whom I've known a very long time, and some who are already heroes because I've spent weeks now immersed in their literature. So looking very forward to having our subject matter experts guide us in the work on utility and security as we go forward. And then closing with community homework and next steps as usual. Next slide. Next slide. We're trying to keep our announcements trim because we have a set schedule of all of our different meetings that happen in different places, and anyone can go to any of them. So instead of repeating what's happening in other meetings, we want you to go to them. If you want to go to the technical meeting, it's on Wednesdays from 1 to 2. You can find that on the HL7 calendar. The Gravity pilot implementation workstream kicks off again at the end of this month, starting on February 29th. This is the last Thursday of every month. All that information is available on the Confluence, so please come and join us. So we just want to make sure that we get people where they want to go instead of rehashing every single meeting, every place. Next slide. This is a brief overview of Gravity. So what is Gravity? It's a collaborative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. This is the program management office. This is the leadership team that I get to work with on a daily basis. Myself, I'm the director of terminology, and I've been helping lead the pilot and implementation area. There's Corey Smith, our amazing technical director. He's what I call my partner in the good. He comes to us from the American Medical Association, and I believe he's on the call, and if not, many other members of the AMA team are on the call, or we're so grateful. And then Vanessa Candelora is our Gravity Project Program Manager. Next slide. Just the lexicon of where we start, again, just to ground us. So health equity is a state in which everyone has a fair and just opportunity to attain their highest level of health. There's many definitions. This is the one that we use. Social determinants of health are the conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources. This comes from the World Health Organization and HHS. And importantly, and we use this in our work as we go forward, it's important to note that social determinants of health can offer both positive and negative forces. We do not just focus on risks in our work. So positive forces are protective factors. As a family practice clinician, I try to leverage these on a daily basis. And then there's negative forces, and we follow the Gottlieb and Alderwick lexicon of social needs, with social risks being adverse social conditions associated with poor health, and social needs being patient prioritized social risks. Next slide. My connection is so bad. All right, can you guys still hear me?
I can, Sarah.
Yeah.
Okay, I'm going to turn my video off because my internet is lagging over here. So we just wanted to make sure that we understood the role of how the work that Gravity does intersects with the general goal of health equity. It's really in the standard support health and human services integration, and then the ensuing analysis of these to enable structural approaches to addressing health equity upstream. Next slide. These are our basic 3 use cases. There's a few more use cases that we detail in the implementation guide, but our base use cases are documenting social care data at patient and client encounters, tracking social care interventions to completion. Again, we do try to think in both person level and population and structural strata. We think about this both in our use cases and in the terms we build. Our last use case is gathering and aggregating social care data for uses beyond the point of care. Again, just reiterating that it's the population and structural activities and the policies that come from them that really address the upstream causes. Next slide. And these are our data use principles. This is the last overview slide. So from a social justice and data justice lens, we cannot do our work without understanding the risks inherent in creating the data that we generate. So we early in our work created these 3 and anchor in these 3 principles. They're called the Gravity Data Use Principles for Equitable Health and Social Care. First principle is improving personal health outcomes. Next principle is improving population health equity. The next principle is ensuring personal control. The next principle is designing appropriate solutions. The next principle is ensuring accountability. And the last principle, very importantly, is preventing, reducing, and remediating harm. All of them are accessible in the Confluence for reference, and they do guide our work and considerations of its impact. Next slide. And just last update is we're very, very grateful for all of our sponsors. Again, this is a member-driven and funded organization. We have lots of wonderful new sponsors coming back into the fold and coming to support our work, really driven by the implementation of our standards. And we're really, really grateful for all of their support. And if you want to become a Gravity member or your organization does, please join us. We have a really great member-led model for prioritization and driving the use cases that affect our work. Next slide. All right, next slide. This is our historical roadmap. This is for those of us who've been here from the beginning, and some of you have. The Gravity Project was kicked off in 2017, 2018 as a collaboration with UCSF Siren and EMI. We launched in 2019 with food insecurity. And then you can see we've addressed 19 domains since then, and we've published multiple versions of our implementation guide. We addressed digital access and digital literacy in 2023. We're focusing first on utility and security in 2024, but you'll see layers of other projects lay on top of 2024 as we go forward. Again, the value sets and information and literature on each of these domains that we've addressed over the course of our time is available on the Confluence. Next slide. This is a rough idea of what 2024 might shape up to look like. So here we are kicking off utility and security, and then terminologies in that green, right? We talked in the fall about the work to develop billable codes and discrete codes for the food, for interventions for food, coding for food. So that might be kicking off very shortly. We are conceptualizing how we might consider working on a way to organize the programs that we are building within social care. And then there's a few domains we can imagine entering the roadmap in the fall. We always have our summer break in general for this kind of work to allow us to build and submit terms. And we build that same break that we're coming off of in the winter. Some pretty exciting things happening over in the integrated workstream world, both terminology and technical. Our members are leading discovery, use case discoveries on social care payment and reporting, and interventions and outcomes tracking. These are both member-led from implementation, but also coming directly from the social care voice co-design work that we led this past year with Civitas. Of note, the final report on that social care voice co-design should be out any day, and so we'll definitely be talking about it when we come back in a couple of weeks. The Gravity SDOH Clinical Care IG keeps on ticking along. They're working on updates there, and then we have our connectathons and our implementation work groups. It's an exciting world. There's some terminology releases coming down the pike, which will get analyzed for integration into our value sets. So those 3 work streams, terminology, tech, and pilots, are busy. I can attest. Next slide. Any questions on anything? And maybe questions on the roadmap or questions on anything I mentioned so far? Let me just make sure there's no questions in the chat. No, I don't see any. Okay, so now Hamali's, now we're going to go into the meat. We did our overview. We talked about the roadmap. Next slide. Next slide. This is the team of the Gravity Terminology team for anyone who might be new. There's me and then the amazing team I work with who are really the wizards of the work. Hamali Sejwal, she comes to us from EMI. You know her very well because she presents on a lot of the updates in the terminology workstream. She's our clinical informatics lead. The amazing Monique Van Berkom. She comes to us from the American Medical Association, incredible expert across terminology and tech. And Sarah Bahal, she also comes to us from EMI. She is a rising terminology analyst, really critical to the work that we do, and has been with us for some time. She also keeps us together. Next slide. All right, so the general work of the work stream is to develop terminology across 4 key activities: screening, assessment, goal setting, and treatment interventions. These are our 19 domains, and then testing and validating social risk data for use in patient care, care coordination, population health management, public health, and clinical research. Next slide. This is an example of that work we did with food insecurity. You can see the screening instruments, diagnoses, goals, and procedures. These are now all in the ecosystem being leveraged and referenced by regulations and quality measures and patient care across the ecosystem. I use these terms frequently in my clinical practice. Next slide. All right, now off to Hamali to give us an update on value sets and some updates within the terminology build. And then we will move to our utility and security kickoff. Hamali?
Thanks, Sarah. So since we met last time, we paused, took a break so that the work that we did in digital literacy, digital access, and utility and security can be put together in a value set, which is now published in VSAC. So as you can see, as our standard update, we built screening assessment, which is a panel level value set. Then we collect all the questions which are applicable for the specific domain from those panels into screening assessment questions. And we have another value set which represents the screening assessment answers. So for digital literacy, since there is no existing tool in the ecosystem for which there are low code, Gravity has identified the key screeners, and we are working with Region Strip for its inclusion in Loink. Once those codes are available in Loink, then we can include them into value set and publish them in VSAC, but that is work in progress. Similarly, for digital literacy goal, there is no existing Sinomed City code. We are working with Sinomed City, US and international to get those added into Sinomed City. But we do have the digital literacy diagnosis codes from ICD and Sinomed City, and also procedure and service request code. So we were able to build those value sets in VSAC. It is initial set of codes which is available. There will be additional codes that we are working with. Once those get published in the related terminologies, those will also be added to those value sets. For similarly for digital access, we have some existing screeners, but we are building upon the ones those are approved by this team, by this group, as well as the subject matter experts, and working on the digital access goal value set. Other than that, all the initial value sets with the existing codes are available in VSAC. The links are shared in the slides here. If you click, and if you have access to VSAC, you can access those and download them for your reference. Similarly for utility insecurity, because utility insecurity partly is covered in material hardship and housing instability, we do have some of the existing codes that we were able to review with the community in the last session, and we were able to build the value sets for that. Again, the full-blown value sets and related codes will be available once we complete these domains, and once the data elements are identified and those are built into Sinomed City will be transferred to VSAC. But these are the initial value sets that we build after completion of the domain, and they are all available in VSAC where the codes are available. We also keep a track of all those value sets and build on a conference page. So sometimes it is challenging to go into VSAC and identify because VSAC, everybody uses it, and it's challenging to find exact value set that you are looking for. So all the value sets which are related to SDOH built by Gravity, we keep a track of all those value sets on a conference page table. You can see the name. They are organized by name and specific value. We try to replicate exact value set name in the conference, so it is easy for you to navigate from this table to VSAC. We provide the VSAC link where available, and also we put together a screening instrument spreadsheet that reflects the triplet of the screener or panel name, related question and answer pair. So when we are looking for a question and answer pair in VSAC, the logic cannot be reflected due to limitation of VSAC, but we can always reference to the spreadsheet to identify that logic. So this table is up to date and available for your use on conference. So that's a quick update from where we paused last time. With that, I will pass it on to Sarah for ICD-10 and other updates.
Thank you, Humali. The busy work of value set maintenance. Lucy, I see you have a question. Can I help? Hi.
Hello, Happy New Year, everybody.
Happy
If you could go back to slide 23, please, for just
Yes.
a moment.
We can do that. Okay.
Yeah. One of the things that I'm trying to understand in the new year is a distinction that's been pointed out to me by various parties between the concept of screening and assessment.
Mm-hmm.
There are a lot of professionals who deem these activities to be quite different.
Yeah.
So I'm wondering how Gravity, or whether Gravity is going to get into this for all of our value sets. Is possible. I certainly don't remember that screening and assessment are conflated, but they certainly are here. And so I'm raising the question about whether, and therefore, if so, how we are ever going to address this. Thank you.
Lucy, that's an excellent question. And I am happy to say we talk about this a long time, and I'm going to do we talk about this often, I should say. And I'm going to give you the gravity answer, and then my team will help me understand if I got it right. So I think that we hear this concern from implementers, and I also should note, I wear a few hats out in the world. One, like working with CMS and working with in other implementer set areas. So what we hear is that the concern is when screening is the only kind of assessment, or is the primary kind of assessment. But certainly screening and using a validated instrument or using any instrument is a type of assessment. And that is why we build them this way. It is not the only type of assessment. You can have a conversation with a person, right? You can do even a physical assessment and not use a screening instrument. But screening is a type of assessment, and that is why we've used the word assessment here, but it's only one type of assessment. And that is in line with the way, the CMS is conceptualizing it in other areas. And I think we tried to do that here very clearly by making sure we had both terms. I understand maybe it'd be helpful to communicate that some way, but again, it was to say that that there are many different ways to assess things. Screening is one of them. And this is why we've labeled it as such. And we say, what I'm a little concerned about is the coupling of the term screening assessments. Mike, can you help us understand why, given what I just stated? If we know screening instruments are assessment instruments?
I think because of the message that it sends to other potential collaborators in this space. I love the way you explained it, because I think that's the reality of what goes on the ground. But I think when we talk to community partners in any of the work on the ground, we run up against the idea that assessment itself is a step that can't always be bundled. And here we have actually labeled a screening questionnaire that is coded as an observation in LOINC as a screening assessment, which by nature kind of bundles those things together in formal term. And that's the undercurrent that comes back when this gets explained.
We do have a lot of discussion on the limitations of screening instruments and the primacy of talking to people, even in our implementation guide. Even what I just mentioned and the limitations of using instruments is woven into everything we do. I'm going to reflect on naming. And maybe our implementer friends can help us offer additional guidance, right, on how to understand these screening instruments as only one facet of assessment. I'm just trying to think.
Yeah, and I'll chime in a little here, Sarah. This is something that we went back and forth on for a very long time, and trying to name it uniformly within our IG. And I think we looked what FHIR calls it, which I'd have to go to our document because we spent a great deal of time on this. I think FHIR calls them screening assessment instruments or assessment instruments, these panels. I think in US Core, they've got now the observation, the SDOH observation assessment or something. I'd have to go look, and they also, their use of screenings versus assessments is very unclear. This is a murky area. I think we went with what you explained, which is there can be general assessments made by a provider with a patient related to social determinants of health. And then there are assessments, which are observations, are kinds of assessments that can come off of screeners. And so we did put a lot of debate into it. And I think there was some input from even, people in connect-a-thons and these calls, et cetera. But it's still a valid point because the fact that it's getting raised shows that it's confusing, you know, and so it's something we can take into account and look at. But, you know, these names start to sort of perpetuate. They're in our IG, they're in our value sets. So it's a little hard to change. And it's just a name here, you know, it's not saying how you have to use it but I understand the points being made.
We certainly do, because we do hear about it a lot. And I think the thing is that, yeah, we hear about it a lot. I mean, certainly social care entities use assessment approaches, standardized assessment approaches. We know this, whether it be the social care matrix or assessment instruments that you use when you're putting someone through coordinated entry, or, you know, it's the role of using assessment instruments to identify concerns in formalized ways is not unique to medical care, right? It happens in that we have a whole database of social care assessment instruments that social care entities have sent us, right? So I think it's a good thing to get continual implementer feedback on. But Lucy, that's the history of why it's named this way, is because we acknowledge that assessment happens in many different ways. And so we tagged it as assessments because it appropriately is a kind of assessment, and have it as being screening to say what type of assessment it is.
Yeah, and I
and
think in RIG, we tend, you know, in the section that talks about assessment instruments, we call them social risk assessment instruments, standardized social risk assessment instruments, and you know, which are also screening assessment instruments or screening assessments. So it's all a bit fuzzy.
But good to raise it again. Good to revisit naming conventions. That's the history of where we've been, Michael.
Well, I appreciate I really appreciate hearing this. And I would just observe that underlying all the gravity work since the very beginning of 2019, and it's really incredible that here we are, understanding and having consensus about uniform language and concepts really underlies everything that we do.
Yeah.
And what I'm encountering is an insistence within the social care context that assessment is what they do, and whether the healthcare providers think that they're doing assessment, which they call screening as the first step or whatever, that's cool. But within the social care context, the term assessment refers to professional understanding, training, and tasks in a way that I think Gravity needs to think about and maybe evolve to consider, just to recognize that what we do in the health sector and the language that we use and the incredible triumph that we've had standardizing language or talking about the social determinants does not seem to easily translate into the organizations and agencies that we are referring to deal with social determinants.
I want to state that this particular, look, Lucy, thank you. I do want to say this particular topic is also really well addressed in the Social Care Voice Co-Design report that will come out very shortly, right? And I also want to state that what you said, Lucy, regarding the differentiation between where assessment happens, there's a lot of conversation on that, because I work in an FQHC where there is no boundary between social care and my clinical setting. They are in my house, like we share a house. Coordinated entry happens in my building, WIC is in my building. And so the boundaries between how that gets conceptualized sometimes are just not, they don't actually play out in practice. And so, but again, there's
Sarah, they may not play out in your practice, but we need to recognize, I think, that maybe everybody, unfortunately, is not as well integrated and well organized as your practice.
Correct. No, I'm speaking about FQHCs in general when I state that, because that's part of the model of community health centers. But you're right, Lucy. And I do want to state that this topic is, again, we convene social care experts to discuss things just like this summer, and there's a lot in it in the social care voice co-design report. And frankly, if we need to convene other groups to make sure that we're all understanding the language we use, we should do that as well. And we
Okay, that's great. I just wanted to raise the question. Obviously, we're not going to fix this in this conversation, but I think this is a task for the parking lot.
Well,
This
yeah.
issue is not resolved yet. Okay, thank you.
Correct. It is not resolved yet, and yes. Okay.
Well, and I want to be clear that, you know, these words are used across different domains, and to get them into terminology systems, they can't have specific meanings in one domain versus another. But what we are trying to do is, you know, the profile in which we allow the responses to these screeners is called observation screening response. And the profile in which a provider makes an evaluation of a patient is called observation assessment. And, you know, we try to use these words as clearly as we can, but it is a very difficult balancing act.
And we'll continue
Thanks, Monique.
yeah, we'll continue to make sure that we are integrating, you know, and thinking about these concepts well. Jonathan, I do want to make sure we get to the kickoff. Jonathan?
I just wanted to kind of chime in and say, I think that as you continue to do this work, there's going to be some standards and patterns that develop. And I think that whoever mentioned talking to the implementers about what makes sense to them might be a good intersection to try to combine what that terminology looks like.
Yeah, and I do want to reiterate that was part of what we did with social care voice co-design, and that report will come out very shortly. But there's more work to be done there. But yes, and again, I can see these conversations happening really elegantly in the implementation work stream. And you know, those use cases we're exploring came out of their work. So we're really looking forward to diving into that and continuing the conversation. But at least we understand that Gravity's thought about this. We definitely don't think we've necessarily getting it perfectly. But you know, we try to describe the importance of true in-person assessment within the IG very clearly, and Monique and a few other members have raised that. We try to describe screening as it being only one type of assessment, and we try as best as we can to listen and learn with you all as we go forward, and we look forward to doing better as we keep on going. So a few coding submission status updates before we get into the kickoff. Excited to say that our ICD-10-CM submission for digital literacy and some updates to housing instability to allow specified housing instability outside of the terms we have right now are going to be discussed in the March 2024 ICD-10-CM working group meeting. I'll be presenting. I look forward to seeing you there. SNOMED CT, we have some SNOMED friends on the call today. Incredibly grateful as always for our longstanding and very dedicated and you know, I would say fairly inspirational relationship with SNOMED and US and international. And so we're working on them to submit the terms from digital literacy and digital access. And as always, we have an ongoing relationship with the registry to make sure we have all of our core critical screening assessment instruments attaining author permission to get them into the digital domains. Next slide. All right, and so now we are going to kick this new domain off and look forward to having you all learn with the amazing subject matter experts we have today. Next slide. This is our little model. We're in identify stage. As you can test, the pre-work was robust. Lots of literature gathered. It's really helpful the fact that our subject matter experts contributed the heft of the literature out there regarding these domains. So we're going to be spending the first period of our time in this identify phase where we figure out what we need to say. Again, we did have some existing terms for material hardship build in the past, so we're starting with something in hand. Then we'll do our end-to-end review and do our vote, and then go into build and test and evaluate. Next slide. So this is the course of events, and again, you can see maybe once they come into fruition, there'll be additional domains layered on top, like maybe the coding for food work might kick off in early March. And we don't quite know, but we're thinking that's what might happen. And then as per usual, we look forward to a 4-month process, or almost a full 4-month process, and then we close out with the utility and security consensus voting in May, and give ourselves a time to submit all of the terms we can in deadline to the next round of terminology submissions. Next slide. All right, next slide. It is my honor to speak ever so briefly about the 3 amazing subject matter experts we have with us today: Dr. Diana Hernandez, Dr. Deborah Frank, and Dr. Stephanie Edniger de Cuba. I'm going to read their bios in turn, and I know you will be as impressed as I am. These are really heroic leaders in the field of utility and security, and specifically energy and security, and we are very, very grateful to have them on board. If you go to the Confluence and you look in the reference sections, you can see just a few examples of the literature that they've offered to the ecosystem on this domain. Starting off with Dr. Hernandez, Dr. Diana Hernandez conducts research at the intersection of energy, equity, housing, and health. A sociologist by training, her work examines the social and environmental determinants of health and has studied the impacts of policy and place-based interventions on the health and well-being of socioeconomically disadvantaged populations. Her foundational research on energy insecurity, defined as the inability to adequately meet household energy needs, has explored the multiple dimensions of this phenomenon, identifying sociodemographic disparities, adverse consequences, and promising interventions towards energy equity and justice. Much of her community-oriented research has been done in collaboration with community groups and government agencies around the country, including in the South Bronx, where she has led small-scale housing redevelopment projects. Dr. Hernandez has published over 75 peer-reviewed articles and book chapters in leading academic journals such as Social Science and Medicine, Journal of Urban Health and Energy Policy. Her work has been funded by the National Institutes of Health, the Department of Housing and Urban Development, and the JPB, Robert Wood Johnson and Alfred P. Sloan Foundations, among others. Professor Hernandez teaches graduate level courses on qualitative research methods, design and analysis, public health leadership, and energy justice. She is a mayoral appointee to New York City's Environmental Justice Advisory Board. Dr. Hernandez has written for and been featured in various media outlets, including the New York Times, USA Today, BBC, New York Daily News, and City Lab. Her first book about energy and security in the US is due to be published in 2024, and she just released a pretty amazing article on Tuesday. Dr. Hernandez, welcome. Next to Dr. Deborah Frank. Dr. Frank graduated from Radcliffe College, summa cum laude, 1970. Following college graduation, she worked as a social work assistant and a research assistant from 1970 to 1972. During this time, she discovered that she wanted to serve young children by becoming a pediatrician. In 1976, she graduated from Harvard Medical School and completed her residency at Children's Orthopedic Hospital in Seattle, Washington from 1976 to 1979. Strongly interested in child development, she served as a fellow in child development from 1979 to 1981 under Dr. T. Barry Breslin at Boston Children's Hospital. In 1981, in response to a growing number of Failure to Thrive families, she founded the Failure to Thrive program at Boston City Hospital, which is now the Grow Clinic at Boston Medical Center. The program has several thousand underweight children. Dr. Frank has written numerous scientific articles and papers. That's an understatement. Her work is focused on breastfeeding promotion, women and children affected by substance use, nutrition among homeless pregnant women and children, failure to thrive, food insecurity, and the heat or eat phenomenon. We'll be hearing a little bit about that today. The dilemma that many low-income families face in the winter when they have to make the critical choice between heating their homes and feeding their children. She's a founder and emeritus principal investigator of the Children's Health Watch, formerly the Children's Sentinel Nutrition Assistance Program. Cited as a respected authority in her fields, Dr. Frank has frequently given testimony to state and federal legislative committees on the growing problem of hunger in the United States and its effect on children. Personally, I will note that when I did my master's a long, long time ago, Dr. Frank was my hero, who I reached out to assist me in that work. Hello, Dr. Hernandez's child. Welcome to the meeting. And then Stephanie Edinger Cuba. Dr. Edinger de Cuba has worked on issues of social determinants of health for young children and their families in program, policy, and research roles for more than 2 decades. She has published widely for academic and policy audiences on a variety of subjects from food to housing, healthcare access, and their connections to environmental exposures. Her particular focus is the health of immigrant families with young children and the intersection of race and ethnicity, social and immigration policy. Recent research includes working with the NIH EPA funded Center for Research on Environmental and Social Stressors in Housing Across the Life course, on the HEAL project, which focused on the effects of environmental exposures and material hardships on the birth outcomes and growth of young children. Dr. Edinger de Cuba previously worked for the Agricultural Health Study at the University of Iowa College of Public Health and served as a Peace Corps volunteer in Bolivia, focused on small-scale agriculture and nutrition and hygiene education. She received her BA from the University of Michigan and her MPH in International Health and PhD in Health Services Research from Boston University School of Public Health. Dr. Edinger de Cuba is Executive Director of Children's Health Watch, a research and policy network, and research associate professor with the Boston University School of Public Health, the Department of Health, Law, Policy, and Management. She has secondary appointments with BUSPH's Department of Community Health and BU's Chobanian, and I can't say this, Avedison, you're going to wave it by me, you're so sweet. School of Medicine, Department of Pediatrics. She also serves as Associate Director for Mental Health with BU's Initiatives on Cities. My word. These amazing experts. I do want to note that, well, first of all, these 3 leaders in this field I just respect them all so greatly, and I know you will too. I've known some of them for quite a long time, and it's just an honor to have them with us. So we're gonna, they will be our guides as we go forward. They're doing the behind the scenes subject matter expert guidance. One of them will be coming to each of our terminology meetings to help us make decisions in real time, and we are incredibly grateful for all of their wisdom. I do want to note the Children's Health Watch is a repeat subject matter expert because of their breadth of leadership in this field. If those of you will remember, they are the authors of the Hunger Vital Sign and the Housing Instability Vital Sign. We were honored to work with Children's Health Watch on food insecurity work and housing work as well in the past. Welcome, SMEs. We're honored to have you with us. Okay, next slide. We all know that over the course of our time, I'm just going to do a little higher level introduction, and then the SMEs each have presentations on their areas of work and health risk associated with their work and with these domains. But we always try to start out with working definitions, and we're honored because we are working with such experts. I can reference theirs. So the general title for this area was utility insecurity, and we note in the literature at times it's used interchangeably with energy insecurity, but we have delineation to do. We'll be doing that internally with the SMEs and bringing that back to you as we go forward, because it's an evolving definition. We want to make sure that we center their guidance on how to make sure that that we do it correctly. Specifically led by these amazing experts, there is a concept called energy insecurity, defined by Dr. Hernandez in the attached article as the inability to adequately meet basic household energy needs. And then, of course, defined by our other subject matter experts, both Dr. Edinger de Cuba and Dr. Frank, through the work of Children's Health Watch, as limited or uncertain access to enough home energy to sustain a healthy and safe life in the geographic area where a household is located. They even go so far as to differentiate moderate and severe energy insecurity. The papers, they are cited for these definitions are in the Confluence again, as are Dr. Hernandez's conceptual papers on energy insecurity. I do encourage you all to read them. They're very accessible and they really help us as we try to figure out definitions and terms going forward. You can find them on the Confluence. We do want to note that utility insecurity has been our meta bucket Utility domains and current CMS instruments cover areas beyond energy and security, such as water, et cetera. And we might have to figure out how to address them separately, but this is the working field for us as we go forward in our work. Next slide. I just want to note as well, and you can again see this in the conceptual work of both Children's Health Watch and Dr. Hernandez's work. This is kind of where we level set always, as with other domains, the dimensions of social insecurities always need to be considered as we craft definitions and associated interventions. This worry, stability, quality, quantity, safety, cultural acceptability framework as the dimensions of insecurity really comes from some foundational work of food insecurity that has, permeates through lots of other domains. When I was reading Dr. Hernandez's papers, I can really feel these dimensions and subdimensions in her work as well. And again, just in the past, what we've done with these dimensions is try to consider whether we have the right terms to define these concepts, because almost all these dimensions have specific interventions. So this is the framework we've used in the past, and we look forward to applying it as we go forward. Next slide. I love that there's some like old home, nice to see everybody happening in the chat. Amazing, Samantha Morton. So now I have the honor of turning over the presentation to our subject matter experts. We're going to center first the work of Dr. Hernandez and then the work of Drs. Frank and Edgar de Cuba. And we always try to do our kickoff with a grounding in why it matters. The specifics of the terms, the instruments that we're selecting, the definitions we're crafting, and all the programs that will come over time. But the why it matters is where we start. And so first we're going to have you go to the next slide. This is Dr. Hernandez. We were able to integrate your slides directly into the presentation. So Sarah Himali will lead if you just want to say next slide, but all of this work comes from the slides that were provided by our amazing subject matter experts. And Dr. Hernandez, starting with you.
Amazing. Hi, everyone. So grateful, Sarah, for a very generous introduction, and amazing to just be in this process and also join forces with the other subject matter experts whom I respect and appreciate so much. And Sam Morton, I have to say, I haven't seen you in so long, but it's so great to see you. And this all kicked off in many ways from my dissertation project. And I'll tell you why it matters to me before getting into the work. So I remember being in people's homes doing this home-based project and asking about like well-established issues at the intersection of housing and health. But what I was observing and witnessing when I was in people's homes was this other like undefined issue that was very present in the lived experience, but also in the narratives that people were describing in terms of financial hardships, like sources of financial hardships, but also sources of physical discomfort and strain. And so I remember sitting with that data. It was a qualitative project and not quite knowing what to do, but really feeling the responsibility to tell that story and to voice those concerns. And so part of this work is about lifting up and validating an experience. I have a little one, so she's tugging at me and I think wanting to be in the fold. Next slide, please. So this paper just came out, and I will very quickly kind of describe what it is. I'll just say that this is very much building on the foundational work of Dr. Deborah Frank and John Cook and company at Children's Health Watch, where they had validated like a brief indicator of energy insecurity. And has done, they did some really wonderful work in making associations between food insecurity and energy insecurity and children's developmental outcomes. And we've used that as a launching pad for exploring it in a local community setting, so outside of the clinical domain, and then most recently in a representative sample in New York City. Next slide. So we've already gone over this, but one of the things that like the definition that I provided in this work has been very intentional in thinking about it as kind of multi-dimensional and highlighting that there's a physical aspect of this, which is very much rooted in housing and the built environment, an economic aspect of this, and then an adaptive component where coping with these hardships, be they physical or economic, both in a way to kind of prevent, but also to respond to the issues, is very characteristic of energy insecurity. And the reason why I put forward this idea that it's multidimensional is that for some households, it isn't necessarily about whether or not they're paying a utility bill. And it was actually in interacting with people living in public housing that I came to realize that one could actually be energy insecure, but not actually pay a utility bill. And for that reason, I thought it was important to be more complete about the definition of energy insecurity and really factoring in the housing connection. Next slide, please. So we completed this the first representative study of energy insecurity and health in New York City. And we wanted to kind of translate what's already been established from qualitative work and leverage some quantitative measures of this domain. And we built out these we didn't validate them. We just wanted to have at this stage right now a number of indicators that point to the complexity of the issue. Next slide. And in so doing, we follow those domains that I had previously talked about, trying to get to like the essential qualities. Basically characterizing the physical conditions as being too hot or too cold. The economic dynamics as kind of being reflective of difficulty paying utility arrearages, disconnection notices, and shutoffs. So this kind of escalation of risk. And then coping strategies, including reducing the use of an air conditioner because of the operational cost, not running heat because of the operational cost, reducing energy because of the cost, also like to save essentially, and then using a stove or oven for heat. And some of these, so the stove or oven for heat, the disconnection notice, the service disconnection, and not running an air conditioning or cooling air conditioning or heating device for because of the run costs are the kind of initial four that were presented by Dr. Frank's group in the paper where the first author was John Cook. What we see is the prevalence of this is in the second column. Is that the most common one among New York City residents is actually reducing energy use because of cost. And so I see that as probably a preventive strategy in order to kind of manage the forthcoming costs. And then after that, there are the thermal discomfort issues, the difficulty paying, and the utility debt. And you can see that as the risk of disconnection increases, the prevalence actually decreases. And then using a stove or oven for heat, followed by the use of basically reducing air conditioning. Next slide. So this is just a kind of a visual depiction of the 10 indicators, which I've already gone over, but a big part of what we're aiming to do in our on our team is to make this work a bit more palatable and reach wider audiences. And so this is the reason why we've been using kind of more science communication tools for the purposes of getting the word out. Next slide. Basically, we actually measured energy insecurity in this case as kind of a cumulative burden. And we are reporting on households that described having 3 or more of these indicators. And so doing, we found that about 28% of adult New York City residents experience energy insecurity. And that it kind of goes along well-recognized patterns of inequality, so that Black and Latina residents were more likely than white residents to experience energy insecurity. Renters were more likely than owners to experience energy insecurity. Recent immigrants versus longer-term immigrants also more likely, and households with children, again, very connected to the work that's been done by Children's Health Watch. Next slide, please. Very importantly, so this work does a few things that I think are important. One is that it starts to quantify the experience of energy insecurity using these kind of indicators. And then, with the lens of a cumulative burden, it validates a lot of the social vulnerability axes that have already been established in the literature. And also, it does another kind of good thing, which is, or important thing in this literature, which is to say that it's also associated with medical vulnerability. So that people experiencing 3 or more indicators of energy insecurity are also more likely to present with poorer health. Next slide. So we found that among households that presented with 3 or more indicators of energy insecurity, there was an adjusted odds ratio of 3.9 for also presenting with mental health conditions, an adjusted odds ratio of 2.2 for also presenting with respiratory conditions, of 2.5 for cardiovascular disease, and importantly, 3.4 adjusted odds ratio of also presenting with medical device dependence. And the irony, of course, in this context is that we're talking about people who are requiring energy for their medical device use. And so it's not an insignificant finding that there's kind of this adjusted odds ratio of 3.4 for those who are actually relying on electric medical devices. Next slide. So, just to kind of wrap up, of course, this is really situated in established housing and health disparities. We see this in who is most at risk of experiencing cumulative energy insecurity indicators. We also know that this is an important tool, in this case, actually, for screening purposes. I mean, part of the problem is in establishing the problem of energy insecurity and making kind of concrete paths forward is that we haven't done a good job of creating consensus and even deepening understanding of what the indicators ought to be, or the assessment tools, etc. So this is kind of a step in that direction that deepens and builds on established work, but also is kind of getting at some of the nuances for the purposes of advancing understanding and also evaluating really a shifting landscape when it comes to climate policies, energy policies, etc. This was done with the New York City Health Department, and it really was a proof of concept in how this work can be done in partnership with local health departments, where some of these issues are also more contextually rooted and different. New York City, for instance, has many large buildings where the energy costs are shared. That isn't necessarily the case in other settings. And so this is really kind of a way to promote those kinds of partnerships. There's also implications for continued measurement refinement of the energy insecurity construct. And so we wanted to be able to, again, lay a foundation for this work and know that there's more work to be done. And this is a real demonstration of that. And that fundamentally, what we're talking about is that access to affordable and sufficient energy and energy efficiency in a comfortable home environment is key to advancing health equity and climate change adaptation. And with that, I'm happy to pass it on. Thank you so much for the opportunity to present. Oh, I'm sorry. And one last thing, not only do we want you to read the paper, but another piece of the work that we've been doing, I have this amazing team of students, and I'm just so heartened by just how hardworking they are and committed. But we have this whole social media campaign called Hot and Cold NYC. It's on YouTube, it's on Instagram, on TikTok. We have tens of thousands of views and impressions. And all we're doing is humanizing and making more accessible the problem of energy insecurity so that people actually see and can experience, along with our participants, what it's like to live under these circumstances. And so I wanted to just acknowledge that and invite you all to read and follow our work.
Dr. Hernandez, thank you. So we even included this. How could I not? I'm like gonna give a little odds ratio slide.
You see, we're trying to visualize to make it easier for non-scientists.
I love it. I love it. I am sure all of you are as aware as Samantha was, and we are now, how lucky we are to have the expertise of Dr. Hernandez. Specifically to come to bear with their expertise about maternal health and perinatal health and the health of young children. I am now going to center, if we go to the next slide. Again, thank you, Dr. Hernandez. I put the paper in the chat. The paper is also on the Confluence, hot off the press. Read it. You'll be hearing more about it as we go forward. I now have the honor of having Children's Health Watch come to speak again. Just, incredibly significant organization in the health of young children and health equity. Dr. Frank and Dr. Anna DeCuba. And again, like Dr. Frank, it's nice to see you. I haven't seen you in a little while, but yeah, she's who I wrote. Oh my God, I don't know. We know how many years ago was my master's. But welcome. So Stephanie and Debbie, you go.
Oh, I thought you were presenting, Sarah. Okay.
Oh, I just presented. So Deborah said, Debbie,
you
here,
you
I
were.
can
I can jump in. That's fine. And Debbie can
No.
too. Debbie, you want to go?
Yeah.
Yeah, I was about to say, I think I'm the bedside picture and Stephanie's the big picture. And so I basically got into this because I was taking care of underweight babies. And I didn't even think about energy. It was food, 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 food. But then I would say, people would come to me and want letters so their electricity wasn't turned off, so they could have either cook the food for the baby or run the nebulizer that I and my pediatric colleagues have been jumping up and down about for their kids' asthma. And I said, huh? And also my colleague, Dr. Sandels, also Children's Health Watch, really sensitized me to housing instability. And I had one clinical experience as an intern, which I remember but did not put in a big context, which was a preemie baby who came in having stopped breathing. And we talked to the family, and they had gone home to an unheated house and had been trying to keep this fragile child warm with an electric light. So that kind of thing you remember, but I didn't put it together at that stage of my life and my training with the big picture. Next, please. Very much my findings are, our findings are the same as Dr. Hernandez's, but they're totally focused on children. And it's not only just minoritized and immigrant families, but the younger the child, the more likely the family is to be food insecure and energy insecure. And children don't vote. And the other problem, of course, as Dr. Hernandez outlined, is kids with special healthcare needs need more energy. So that all comes together. Next slide. I kind of fell over this. Again, my focus was hunger, 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 hunger. And I wanted to find out how many underweight babies were coming to our hospital that I wasn't seeing. So how are we going to do that? Well, you want to look at the kids who aren't in regular care. So we stood in the emergency room and we abstracted month by month. And in those days, we were using a computer with floppies that could only hang on to the data for 1 month at a time. So we had to print it out every month. I know you younger scientists must be like, I'm talking about riding to work on my dinosaur, but it was a so we printed it out every month and we saw this pattern, which is in the 3 months following the coldest month, we suddenly had this huge uptick in a percent of kids who are underweight. And being in New England, and in New England at that time, our biggest worry was cold. We looked at that and said, that's weird. But I didn't quite know what to do with it until one day I was meeting with some food bankers that I was, trying to shake down for more food for my babies. And I said, look at this we're finding. What do you think that is? And I said, oh, that's heat or eat. So what's heat or eat? And they told me. And they are so right. And so that's how somebody whose passion was food ended up in energy insecurity as well, because they are so tightly linked and so critical for families. Children, have very small surface areas. So they're very susceptible to hot and cold temperatures. And their metabolisms are much faster, and their brains are most vulnerable. Next slide. So we had our, as Dr. Hernandez says, John Cook helped us pull together this definition of severity of energy insecurity. And a colleague who was running the ER at the time, who we met with about this, said, and I'm worried about people using cooking stoves as a heating source. I said, huh? And that turns out to be a huge issue. Our cooking stoves were generally gas in terms of respiratory illness and also in terms of fire risk. So we threw that one in that had not been in the Dr. Cook extracted other stuff from national data sets, which I can't remember, but we could pull out. But that one was particularly a pediatric concern. Next slide. So we said our general position is that social determinants of health are written on the bodies and brains of babies. And they're the canaries in the social mind for a huge, starting prenatally, for a huge number of social determinants of health. Because they're so fragile, the impacts show up before they do in the population at large. An adult has a lot more nutritional reserve, thermal reserve, and so on, than a baby. And we look at kids birth to 4. What we found was we knew what food insecurity did to babies and toddlers, but what we found was energy insecurity was correlated in a dose-related manner with food insecurity, particularly food insecurity at the child level, which is the most severe and is something that families stand on their head to avoid. If the child isn't getting enough to eat, the level of deprivation is extraordinary. What mothers tell you is I always has something in their stomach. And if they don't, that's a huge worry. I mean, even the something is usually not very good either. So that's how the concerns fit together. What Stephanie has done is bring in, among many things, is bring in the environmental issues. And as we're learning to go from just worrying about cold to worrying about heat, which has been a huge issue in all of our areas, and also trying to figure it out prenatally. So I'll turn it over to Stephanie to talk about those things, which are, the cutting edge.
Okay. Yeah, no, I think, I think Diana's headed this direction as well, thinking about extreme heat and the ways that environmental exposures, climate change intersects with all of these insecurities and, has even worse impacts for in our case, thinking about young children's health and their parents' health and their families' economic stability. But obviously the effects are wider than that as well. So what Dr. Frank's referring to, Debbie's referring to is work I've done with other colleagues looking at the heat index and exposure during pregnancy to extreme temperatures and how that affects gestational growth and birth weight. And I'm definitely interested in expanding beyond that and thinking about child health. And another big interest, I think, in children's health much generally, and I think driving all this work, and is a theme across all of what you're hearing today, is the intergenerational impacts, right? Because this doesn't affect just one person at a time. What's happening to parents affects what's happening to children, or people in a household. So we have to think across the household instead of a person by person is kind of where our work is really contributed. And I think with health services research background, I think the other piece of this too is, we found impacts on child health, but also increased hospitalization. So kids who are energy insecure are more likely to be hospitalized, which obviously, particularly in very young children, is pretty extreme outcome. So, lots of sort of family anguish and health concerns, but I also would say lots of costs, right? So like that's more expensive. So I would put my
That's our main
hat
hook.
on. Go ahead.
That's what I was just gonna say. That's our main hook with politicians, that they don't care about suffering, but they care about cost.
Right. I was just going to say basically the same thing. So yes, that's right.
More
Somebody put
tactful,
their
I'm
hand
sure,
up.
because usually are more tactful.
Somebody put their hand up, I think.
Jonathan raised it and then lowered it.
Oh, okay. All right, great. Yeah, so I guess so that's sort of like the world of things that we've been thinking about. I think, well, actually, that's not entirely true. The other thing that we've done a lot of work with over the years and thinking about energy insecurities intersections with other needs. So certainly housing, certainly food insecurity, looked at, access to healthcare, and then all of those things together. So what's the constellation of hardships look like? The thing is, as we've all been repeating here, and you all know very well, when somebody's struggling with one thing, they're often struggling with more than one thing. And if it, adding my origin story to this, there's lots of roots to this work, but one of them is I started out, one of my early public health jobs was doing SNAP outreach and helping people sign up for SNAP. And that was the thing that I heard all the time, because you have to dig in, SNAP, you have to ask about their income and their expenses and all the things. So that inherently means lots of conversation about how things are going. And utility costs came up over and over and over again. So that's been a part of my thinking for a long time. Yeah, Jonathan.
So, doctors, I really appreciate your guys' insights and your feedback here. And as I'm fortunate enough to be involved in these conversations, unfortunately, as much as we hate to admit it, I believe that healthcare is human care, but there's a cost associated with that. And I think that sometimes that when we engage in these discussions, the way to be able to set out what the tangible ROI impacts are for like the value of somebody's life and being able to quantify that from a business standpoint, I think is the only way that you're actually going to be able to like shoot the freight train with a BB gun, for lack of a better term, right? Because that's all they understand. And I'm not saying that we minimalize that and we monetize that, but I do think that coming from the public-private sector background and having a hard sales background, like I need the justification for how those dollars are going to be spent and what the expected outcomes are going to be. And I don't mean that we need to like boil the ocean like right now, but I think that the more that we can kind of align ourselves with that ideology and thought process, the easier it's going to be to identify opportunities to engage around these discussions in a more meaningful manner that can actually give momentum to the work that we're doing in these conversations here.
And I
Yeah, I
would
think
add,
Oh, go
sorry.
ahead.
I would add that the costs are not just hospitalization, which is pretty acute and you can also quantify, but long-term developmental impairments. And we found that all these social determinants are linked to less optimal development in young children, controlling for parental education and race, ethnicity, and everything. And so, you know, SPED costs, special ed costs, and so on, are a big concern.
No, that's exactly right. But I mean, in order to have healthy adults and individuals, we need healthy children, and we have to be able to address the root causes of that, right? And if we're not willing to identify what some of those root causes are, and then to be able to point resources in the right directions and effectively leverage that to say, okay, if we're going to address anything in a meaningful manner for durable change, where are we going to start and how do we measure that so we can actually go back and say, we invested X amount of dollars here to impact this outcome here, and this is what we saw, and then being able to use those conversations to move the discussion forward. So I will just leave it at that as somebody who was in the public sector and then has gone to the private sector and considers myself to be a social entrepreneur, and people laugh at me when I say that because I believe that you can do well and do good at the same time. I don't think those things are a binary equation. I think that we just kind of need to kind of be mindful of that as we have these broader conversations.
Yeah, I think those are great points. I think it is some of the work that we have done. We haven't admittedly done it on energy insecurity, but we have looked at sort of like the cost of inaction, right? So how much does it cost for what are the avoidable costs of food insecurity, both medical and educational? And, you know, found that in 1 year, it was $178 billion that we're spending on dealing with food insecurity when we could be spending that in preventive measures, investing in programs, investing in all kinds of supports for family, you know, whatever. So I think that's one piece. I totally agree on that. And that has been effective with, frankly, more conservative folks and for helping public sector folks make the argument for why they should be moving upstream. And we did also the same work for housing instability. We found that over a 10-year period, the avoidable cost of housing instability for mothers and children was $111 billion. And a big portion of that cost, as Debbie pointed out, was children's development and the subsequent special education costs, but also maternal depression. That was a really big portion of that. So.
Well, and the last thing I'll say, Sarah, I know you want to move on, but when we talk about preventative measures in healthcare, it's easier to treat something up front when you diagnose it, right, than the later stage treatment. And so that's what we're really doing. Like, let's move this conversation a little bit further upstream to try to address some more of these issues while they're pertinent and relevant. So we're not actually dealing with them downstream when they're going to be more cost and time bound and time prohibitive. So sorry, Sarah, I've been excited to re-engage in the conversation and
no,
I'll
it's
get
great
off
to
my
have you.
soapbox now.
No, I just wanted to say, when that particular argument you're making, you couldn't be making it to a more appropriate group of subject matter experts. Having listened to their testimony, like their federal testimony, having seen their policy documents, these are people who take the evidence to the mountain consistently. Like that is the mission. And so all of these people are, I mean, you hit the nail right on the head, and you are surrounded by people who are saying yes, 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 and having borne witness to these amazing subject matter experts in DC, knocking on doors, giving testimony. I know you're in very good company. I do want to make sure that we get to, particularly with this amazing group, I do want to make sure we get to the rest of the slides. Debbie, do you have anything you want to state on this slide before we?
Well, obviously, doctors are always interested in treatment, not just in identifying. And we have a treatment for energy insecurity, it's called LIHEAP. And we see it again on the bodies of the babies. The Z-score is a fancy statistical way of looking at baby's weight compared to the average weight. And you can see that it's considerably lower in families that don't get home energy assistance versus those that do. So it is actually visibly there. So it's, people say, well, nothing works with these poor people. Well, nonsense. There are lots of things that work, and we can show it on the bodies of babies. So I would love it if Jonathan could tell us how to get politicians to pay attention to outcomes that won't happen while they're in office.
You send somebody like me in there with a shirt and tie on and look them very straight in the face and be like, don't say that you care about people's lives and you're not willing to invest in them. That's how you do it.
Okay, go for it.
Okay. I think this is your last slide. I just want to say thank you so much to the amazing Children's Health Watch and Dr. Hernandez, Dr. Frank, Dr. Editor Cuba. You saw the dates on some of those studies. 2008 was when I started my master's program. So I was like, hi, brilliant people, I need your help. So I've known them for known them for a very long time. You can see we have a lot of work to do. We can see we are in the right hands. Next slide. Thank you so much. I just want to note that some of the drivers that drive our work, largely driven by CMS, the CMMI Accountable Health Community Model, Patient Quality Reporting, Social Drivers of Health Measure, Medicare mandated assessments, right? So there's a lot of drivers out there focusing on utility insecurity right now and energy insecurity. Next slide. I'm trying to get us to our homework. We don't have time for questions. I'm so sorry. We had to sit in the homework the last few minutes. You will have access to these amazing subject matter experts over the course, and my dog is shaking. My old dog sometimes moves. You'll have access to these amazing subject matter experts and their wisdom over the course of our time. Again, some of their seminal papers and some of their even emerging papers. Dr. Hernandez's recent paper emerged on Tuesday is available on the Confluence. Please read up on that so you can see some of their expertise. You can always, YouTube their testimony too in DC. Please catch up on materials and recordings on Gravity Project. Submit any instruments that you feel like are critical, any programs that you feel like are critical. I know some people have already emailed me some. Really want to make sure that we understand and center on the unique people, roles, and professions that are helpers in this space. Remember, you all created the term community health worker in HIT many, many years ago, so those roles are really important. Next slide. Yes, it is an awesome paper. And then we'll see you again, 2 weeks. We're back in the swing of things. And then you can join technical workstream on Wednesdays. Again, the 29th is our first implementation workstream kickoff. And we are so grateful you are here. Any final thoughts in the last few minutes? And again, just incredibly grateful for our subject matter experts. Some of them I've known for a long time. That's amazing. And Dr. Hernandez, thanks for having your lovely baby with us today. We are a baby-friendly space. Thank you so much, everybody. You have a lovely Thursday, and we look forward to seeing you in 2 weeks.
Thank you, everyone.
Ready.
And Dr. Frank, I have to say it's such a pleasure to finally meet you.
Thanks to all of you for this incredible work. Your citations show how long this work has been going on, what you're building on. So it really impresses on all of us how much time it takes and even generations to effect really substantial change. So thank you for picking up on that work and showing it to us.
Yeah, I agree. Thank you. I'm in Seattle. I think I met you maybe with Nancy Amadei at a school of social work many years ago. Anyway, and she was involved with FRAC and others too. So we kind of end up in a circle, right? So I appreciate everything. Nice to see you, Sarah, and everybody. Thank you, Dr. Frank.
And then Dr. Hernandez, Debbie wrote in the chat too.
I saw that. I saw that. I know, like total fangirl.
We get to see each other on Fridays during our SME meetings. Thank you so much.
It tomorrow, but I will be there next week.
Fantastic.
Bye-bye. Take care.
Bye.
Thank you.
Bye.